All right, I know we're a little behind. I'll try and make up a little time if I can. We'll talk about eye disorders. A couple comments I want to make about anatomy that relate to certain disorders I'll make now because they're not really addressed elsewhere in this topic. So when you're looking at the side view of the eye and the image, you take a look at the anterior chamber. You've got the cornea, you've got the lens. Everything superficial or anterior to the lens is pretty much going to be the anterior eye. That's where a fluid collection can develop. So if you could have blood there, it could be a hyphema. If you have pus there, it's a hypopion, and you can get that sometimes with a staph infection or other types of problems. So look into the anterior chamber for that. That's right through the visual axis, and the pupil is the aperture to allow a certain amount of light to get into the back of the eye and hit the retina and really send the visual image to the brain through the optic nerve. So very important. Outside of the eye, the sclera, the white portion. Just deep to that is going to be the choroid, mostly fibrous connective tissue and blood vessels, and then deep to that inside the eye is going to be the retina. And what I want to mention about the retina is simply retinal detachments. Retinal detachments are easy to diagnose, and you don't really even need an ophthalmoscope to do it. Now, if you're going to diagnose one, you have to tell a patient that they have a retinal detachment, you pretty much have to put that light up to their eye, though. You can't say, I figured it out and I have a pretty good idea that you have a retinal detachment, even though if they complain of flashes of light, which means flashes of light in the periphery somewhere, is telling us there's probably some tension or tugging on the retina, sending an electrical signal to the optic nerve. And if you have floaters with that, particularly new onset floaters, that's a little bit of vitreous hemorrhage, which almost always accompanies a retinal detachment. So if you have those things, a few floaters going by, so you move your eye, and a couple seconds later, these little fibers float by. It looks like a spider web. And you have these flashes of light that you noticed. Well, that's probably going to be a retinal detachment, needs emergent evaluation. So you can send them to the office now, not tomorrow or the next day. It needs to be dealt with immediately. Because the retina can fold up in the back of the eye like a little piece of tissue paper. And if it's not tacked down quickly with a laser, they can be completely blind in that eye. It's a very time-sensitive diagnosis. So back to my point about not needing an ophthalmoscope. At that point, it's just about the show, right? You walk in and sit down with them. Well, I had these flashing lights, and now I got these spider webs going across my vision. You're like, you got a retinal detachment. But there's no way I can say that without using the ophthalmoscope. So you go ahead and use it. Make sure you take a look. I think Billy even mentioned earlier, he may not know what it looks like back there, but it doesn't look normal. And the chances of you getting a good dilated exam are not great in our environment. And you know, sometimes people say, well, gosh, they were squinting, they were doing all kinds of things I couldn't even see. Even if their eyes closed, at least you can say, I saw no abnormalities. And it is a true statement, so at least you have to try. So you go ahead and try. But retinal detachments are easy to diagnose, but it's mostly by the history. All right, let's look at the picture of the left eye looking straight at us. And the main thing I want to mention here is really about lid lacerations, because some errors can be made here, particularly when we're trying to find reasonable shortcuts and save time and get done quickly. Lid lacerations or periorbital lacerations are oftentimes very small. And we oftentimes think it won't take much to repair them. A couple sutures and we're done. Why get ophthalmology involved? If you have significant tissue defect, they need to be involved and have ophthalmology do it, or plastics. If it's involving the canalicular system where you think it should be, so the tear duct system, stay away from it. So let's look at that. Superior and lateral, up underneath the upper lid, is the lacrimal gland. It bathes the eye continuously with tears. It moves medially, and at the medial aspect of the upper and lower lid, there's a punctum right there that reaccumulates those tears. It goes into the canalicular system, into the lacrimal sac, which is inferior and medial, right in here, and then to the nasolacrimal gland. So when you're crying, that's why people get a runny nose when they're crying, because you're draining back down that direction. So anything in that particular area where there's a laceration, don't touch it, because you may not be able to repair the structure and they wouldn't know right away. And then you wouldn't have appropriate wetting of the eye, can cause corneal ulcers and scarring, and that is a huge issue. If it's at the edge of the lid or at the tarsal plate, it's got to come together perfectly, otherwise there can be a little notch. Not when you repair it, you're going to do a great job repairing it. But once it starts to heal, if you haven't done it right and the edges invert just a little bit, you get a little notch, that little section will never get corneal wetting, and you will get a corneal ulcer and a corneal scar. And you may not know for quite some time, and you'll think you did a great job, and ultimately, you've injured the patient, so be careful. And the final one, which I think is a great pearl that I didn't know until a few years back, I find fascinating, is an upper lid or lower lid laceration, but you find this more in the upper lid, I think, when there's just a little laceration, but there's a little fat coming out of it. In other lacerations, what do? Laceration of the hand, the thigh. Do we meticulously tack down the fat? No, we somehow distract the patient. Look, bird, they look over there, we snip it off and throw it in the tray, right? Get it out of there, we don't need it. You can't do that with an eye laceration. Well, you can do it, you can tuck it back down in there. The problem is, there is no fat superficial to the orbital septum. Therefore, if you see fat coming out of a periorbital wound, then the orbital septum has been violated. That must go to the operating room to be appropriately cleaned out and fixed. So it seems small. Oh, it'll only take a suture or two. If there's fat coming out of it, hands off for all of us. We need to refer it. All right, let's move on. One of the important evaluation tips for eye problems is that everybody's got to have a visual acuity on the chart. Even if the patient says, my vision's fine, in a nice way, we need to say, you need to prove it. We need to have it on the chart. What if their vision changes later? Even if they said, well, yeah, I said it was normal, almost, then stories may change. So we want to document what their visual acuity is. Very, very important to do so. And some patients don't even know their baseline visual acuity is dropped, and we can refer them for appropriate evaluation. You want to observe the external eye. Take a look at symmetry, lids, lashes, everything, and document this in your record. It amazes me that when somebody comes into the emergency department with a neuro complaint, how tiny sometimes the neuro exam is in the record. When someone comes in with abdominal pain, how tiny that portion of the chart is. Well, the same thing with the eye. Most of your examination, most of your HPI, history and physical, should be focused, and history of present illness, all that should be focused on the eye. So let's make this a good exam and talk about all the structures that we can see and can evaluate. And let's do that effectively. Now, getting a visual acuity, here's a clinical pearl that I think will help you. And I don't know why this creates controversy, but it seems to. I can't tell you the time I've lost in my life going into a room with somebody with eye pain. The visual acuity is 2400 or 2800. They are completely blind. I walk into the room, said, they checked your vision? Yeah. Oh, this eye is killing me. Well, would you like something for it? Yeah, I'll get some numbing drops for you. Trust me, if anyone in your department check the visual acuity through the lid because the person's squinting, they're blind. They can't see out of their eye when their eyelid is closed and they're blinking. So you numb the eye first. It should be a standard protocol in your department. If their eye hurts, put some numbing drops in it and then get the visual acuity so we don't have to interrupt our evaluation to get the visual acuity after we numb the eye. Now, some people, I don't know where this comes from, but have told me, confronted me and said, you are ruining the ability to get a true and accurate visual acuity when you numb the eye. Well, no, you're not. You're actually facilitating getting an accurate evaluation. You're moving the lid out of the way. And what I love about this, too, I don't remember the exact year, but it was in the 80s. David Sklar, who's the department chair at University of New Mexico, he did a great study on this. 80% of patients, when you numb their eye, if it resolves their pain, in 80% of them, it reliably tells you it was a corneal problem to begin with. That's a great diagnostic tool. So you put numbing drops in their eye, like, oh my God, it's totally numb. It's a corneal problem. That means it's probably not glaucoma. It's probably not some other significant problem with the eye that a numbing drop wouldn't take effect with. And don't put a couple drops in there. I mean, those little tiny bottles, that's a single use. Don't save them. Just completely flood the eye. I worked a shift before coming out here and evaluated a patient. Someone had dropped some numbing drops in there. They had performed a slit lamp examination, but they were having trouble doing it. So I went to the bedside, and the guy's squinting. I said, did they put numbing drops in? Yes, they put both of them in. Both of them. I said, lean your head back. Here's how we do it when I work. Oh, wow, that is so much better. If I need another little bottle, I'll get another little one. But let's make sure it's numb and put a lot in there. Make sure that we evaluate eye motility and document it, and the pupillary exam. We've got to document the anterior segments. We touched on them, but we've got to document they look normal. And we have to make sure that the posterior segments look okay as best we can tell. And a great tool, particularly if somebody's talking about or complaining about visual problems, you've got to do visual fields by confrontation. So I'm going to cover my eye. The person's going to use their hand on that side to cover their same eye, and they're supposed to, unless they cheat, focus right on your nose, and you're going to hold a number of fingers up across their different visual fields, and they're supposed to tell you. You can tell if they're cheating because they'll look at the fingers, and you can say, hey, you're cheating, you got to look at the nose. And then you can tell, will you be able to pick up a peripheral visual field deficit? Yes, you will. And you probably won't need to do it in the central visual fields because they're already going to be aware that they have a visual problem there. Retinal detachment, stroke syndromes, lots of different things. You'd be amazed what you will find when you look for it. So visual fields by confrontation are important. Slit lamp examinations. I think the Woods lamp is really a tool we don't need to use in the emergency department for ophthalmology anymore. It does not have the magnification to detect some of the things we want to, smaller foreign bodies, and it will not detect dendrites. Had a great case several years ago. I was working with a physician assistant who's great. She does a great job, but I think it ended up being a great teaching case for her. Busy shift, she came to me and said, I've got this guy with a corneal abrasion. How did he get it? Oh, he rubbed his eye. What do you want to do for him? Well, she laid out the normal treatment plan. I said, how did you find the corneal abrasion? How did you diagnose it? With a Woods lamp. Okay, let me go see him. Well, I did a slit lamp examination. He has dendrites everywhere. Then I noticed a little malar rash on his face with little vesicles. And how long have you had this rash? That's been there about a week. HSV. And then when I'm getting him admitted, he's getting IVA cyclovir. He said, hey, since I'm here, doc, can you take a look at my finger? I've had these little bumps here for 6 weeks. He had herpetic Whitlow. Auto-inoculated his face and then auto-inoculated his cornea. So that is a bad situation, but it can be overlooked because you're using the wrong tool. The Smithsonian is the best place for that tool, not the ED. So let's get it to where it needs to be, but be very careful. You can really get in trouble using it. All right, so let's talk about basics for the eye. If somebody has a chemical exposure, skip all the components we just talked about and do them later. Let's decontaminate the eye. Let's make sure we irrigate it pretty well. And if they have particulate matter or debris, let's make sure that we get that out even with a moistened Q-tip. If you're having trouble getting a visual acuity because somebody has corrected vision but they didn't bring their glasses, do pinhole correction. Pinhole correction removes or eliminates the refractive errors. And so you can get a true visual acuity then. Now, if you do a visual acuity in somebody who doesn't have their glasses, you can ask them and document, okay, your vision's blurry, but is that normal for you? Yeah, my vision's always horrible, that's normal. It helps to put it in the record, but it's better to get somewhat of a corrected vision if you can. All right, so washing out the eye. Gross contamination, we need some sort of large volume device to wash them out. If you want to wash them out of the sink, that's fine. Make sure you use topical anesthetics and use plenty of it. And we've got to learn to revert the lids at some point so we can take a look under there for foreign bodies and other issues. Anyone do this? This is a skill not learned in medical school, physician assistant school, or nursing school. This was 3rd grade. Your friends learned how to flip their lids up. I used to run around and scare my sister with my lids flipped up. Ah! I don't do it anymore, okay? But it was a lot of fun. But some people just can't do it. If you take a look at this image and you just take the non-cotton applicator side of the Q-tip, just the empty side, and lay that on the lid and pull the lid up, it'll flip up over it. Tell people you're going to do it. It'll freak out people in the room. But that, I've seen many a foreign body missed by somebody trying to look up underneath the lid until they flip it and you find a retained foreign body that's there. All right, Morgan lenses. Everybody have a Morgan lens? So if you want prolonged irrigation, particularly for a chemical exposure, Morgan lens is like a contact lens system that connects to IV tubing. And you probably want 500 to 1,000 cc's. Generally, normal saline works fine, but probably sterile water would work okay, but probably normal saline is a better choice. If you don't have it, what works great is a nasal cannula. Just don't put it in the nose. You've got to put it across the bridge of the nose so that when you connect the end of it to IV tubing, and you can, and it will fit, it will drain right into the eyes. There's going to be some runoff with either of these devices, and there can be a lot of water, so make sure you have a catch basin or something. And if they have an acid or alkali burn, you want to check the pH with litmus paper. So you check it, and you want to be really close to neutral, body neutral, 7.4. Now, this is important for alkali burns, because with alkali burns, you get liquefaction necrosis. and it continues to burn. It can continue to ruin the eye and damage the eye. So until that pH is consistently at 7.4, they're not going home. They might have to be admitted for continuous irrigation. That doesn't happen with acid burns. Acid burns sound worse, but they're not. You get coagulation necrosis with acid burns, and so when you coagulate the cornea, the burning process stops. It's a bad injury, but it's self-limited. It's done. So they will not usually need to be admitted and have continuous irrigation. Okay, foreign bodies. Use topical anesthetics. When they come in, they're going to be uncomfortable. You can remove these either with a Q-tip, and you can go ahead and moisten it. If not, I prefer not to moisten it for this reason, because I want the fibers to branch out so it will grab that foreign body. And there will be a corneal abrasion in that area and around where you tried to pull it out. So I don't think you need to fluorescein them up front. Once you find the foreign body, take it out and do the fluorescein and do the evaluation following that. You can use a small gauge needle, 30, 27, maybe 25, and flick it out. That will work too. And always look for the retained foreign body when you see ice rink lesions. Every time they blink, it may cause another linear corneal abrasion. And if you are looking for a new slit lamp, although this image may mislead you, there are no slit lamps out there that actually show you the arrow where the pathology is. It would be great if it did, the arrow. Rust rings. If you have a small metallic foreign body, you can just use a burr and get the foreign body and the rust ring out at the same time. If you don't want to do this, they really should be referred within 24 hours for follow-up anyway, and the ophthalmologist can use the burr and take it out. You're just creating a little deeper hole than the abrasion, and it'll take a little longer to heal, but that's all we're doing. If there's a high-impact injury, drilling, something that's using a power tool, consider the possibility of an embedded foreign body that's deeper than the cornea, and you're going to want to get a CT scan to make sure they don't have something like that, particularly if they have deep eye pain, headache, those sort of things. Standard run-of-the-mill corneal abrasion is usually a scratch or a poke. Do the slit lamp examination, as I mentioned, very, very important. You can look in the anterior chamber, but get your ophthalmoscope or the slit lamp and shine it in from the side of the anterior chamber, because if you have a microhyphema, it hasn't fully layered out yet, that's blood in the anterior chamber, you might see the particles, and you'll be a real hero to identify a hyphema before it actually layers out and you can see it from the front. Topical antibiotics can be prescribed for corneal abrasions, but just for comfort, and cycloplegics do not reduce the pain of a corneal abrasion unless they have associated traumatic iritis. If they have iritis with it, well then fine, do the cycloplegics with it. If somebody is at risk for glaucoma, they either have a known history of glaucoma, then it would be a mistake to dilate the eye, or they're elderly or have some other risk factors, then make sure you check intraocular pressures with a tonopen or whatever you're using before you dilate their eye. The 25-year-old with no history probably is not an issue. The 65, 70, 80-year-old with multiple medical problems, before you dilate their eye, you want to check their intraocular pressure. It's another tool. How many of you have tonopens? You just kind of tap it on the eye and it beeps and it gives you a number. That's a great tool. That is a phenomenal tool. And for a couple of reasons. Have anyone in this room still using a Schiat's tonometer? I was going to say ever, but I'm sure someone has. The Schiat's where you put the little weights on. Oh my God, what an infectious disease nightmare. I mean, that is a scary thing. And I think that also needs to be delivered with the Woods lamp to the Smithsonian. I mean, those little tiny weights, yes, I think your pressures are elevated. I don't know, put another little plate on. It's crazy that we used to do it that way. Another thing that's just good fun with the tonopen is the little guards that go on it to make sure that it protects the cornea and also make sure that it's not an infectious disease risk or discarded. But they come in a little tiny package, and they resemble, Greg probably commented in his urology lecture, they resemble a very tiny condom. Have you ever been with a coworker and got one of the tonopen sleeves and just dropped it behind them, and when a lot of the staff were around said, I think you dropped something? It's a little bit of fun. You don't have to try it, but if it's a little funny. Okay. All right, beware of abrasions with contact lens wearers, because there is no such thing as a benign corneal abrasion because somebody just didn't take their contacts out early enough. If someone takes their contact out or you take it out for them and there is a residual ring, either a haze around it or fluorescein uptake or a little punctate lesion in the middle where it was at, that is very likely from Pseudomonas. And Pseudomonas is really bad in the eye. When I did my residency training at Charity Hospital in New Orleans, I'll never forget this case, but we had this cardiologist that was a little grumpy. Okay? And we were rounding in the ICU, and we were preparing for rounds for this cardiologist to come in. I had a fourth-year medical student working with me at the time. He was in doing the note on his patient, and his contact fell out of his eye onto the floor of the oldest operating hospital in the country at the time. And they weren't really focused on a lot of housekeeping, okay? Let me put it that way. So his decision was, because the cardiologist is coming through the door right now, I excuse myself, clean the contact, or I rinse it off in the sink, take a little time, let him know what's happened, and tell him I can't present until I'm ready, or bam, I slam it back in the eye. What did he do? Bam, right back in the eye. 48 hours later, rip-roaring Pseudomonas infection. Bad choice. So be careful. When you see this, call the ophthalmologist. Say, hey, you know, I'm going to start them on the standard types of things, but I think you need to see them today or tomorrow. And sometimes, if they're concerned enough, they'll admit them. Eye patches, I'll just tell you, for almost everything, eye patches are not necessary. If you have a hyphema, you want to have something covering it, an eye shield, so there can be no more trauma. But an eye patch isn't necessary for abrasions or anything else. And if you don't apply it right, if you apply it correctly, it should be tight, so the eye cannot move underneath it, and that takes some effort. If you don't, then you're actually putting a small amount of pressure on it, so when they move the eye, it's rubbing. And that doesn't make things feel better with a corneal abrasion or iritis or anything else, or UV keratitis. So you don't need to patch anything. How about tetanus? The CDC said in the mid-1990s that standard run-of-the-mill corneal abrasions are not tetanus-prone wounds. They're not. So all the tetanus shots that are given in emergency departments in this country because somebody has a corneal abrasion really are not indicated. And we want people to follow up in 24 hours. You mentioned that. Very important, because we don't know which eyes are going to get worse, which ones are going to get better quickly. Hyphemas, I mentioned it, but we've got to make sure we look for it, and in trauma, document the absence of it, unless it's there, of course. Can be associated with other injuries as well. You want to shield it, they can go home. The people to look out for are the people who are at risk for increased intraocular pressure, those who have glaucoma, and those who perhaps are sicklers. Sicklers can sludge, and then they can create acute angle closure glaucoma. And the 8-ball hyphema, the anterior chamber is full of blood, must go to the operating room, can't go home. Viral conjunctivitis, this is easy. The reason we mention it here is we want you to be able to differentiate it from bacterial conjunctivitis. This is one eye. It's a little bit red. It's runny. Just like when somebody says, there's a cold in my eye. They're right. It's not more contagious than the run-of-the-mill upper respiratory infection. It just happened to travel up the nasolacrimal duct, and it's in the eye. But if you get a bad case that won't get better and goes to the other eye, and it's really swollen, sometimes that can be epidemic keratoconjunctivitis from a virulent strain of adenovirus. They can have their corneas become very permeable, and they are really susceptible to bacterial secondary infection. So those have to be followed up closely with ophthalmology. But standard run-of-the-mill viral conjunctivitis should go away. One other way you can differentiate this is that they will have preauricular lymphadenopathy, where bacterial conjunctivitis won't have nodes. And that's counterintuitive to me. It probably is to some of you also. But that will help you differentiate what you have. Bacterial conjunctivitis, you're going to have significant swelling, a lot of purulent drainage. It just looks different. In the neonate, remember, neonates, there are some purist neonatologists out there that say if you have neonatal conjunctivitis, they're immunocompromised and they were exposed perhaps to many organisms in the birthing process. They need a full septic workup. So don't just say, oh, it's a little viral conjunctivitis and you're 3-day-old. We'll go ahead and give you some drops and send them home. That would be a mistake, because there's probably something more significant. And we've got to decide if we have a pathogen that's concerning, like GC. So gonorrhea can result in perforation in the eye, and it doesn't take too long. The scary thing is, gonorrhea in the eye almost always is from auto-inoculation, self-inoculation. Boy, if that isn't a social misadventure, I don't know what is. If things are not right down south, don't travel it and transport it up north. Leave it where it is and go see the doctor. Okay? Seriously, but that is the #1 way that people get gonococcal conjunctivitis. So look out for it, because it's really a lot of swelling and a lot of drainage. Topical antibiotics are okay for this. They may need IV antibiotics. And just remember, Blef10 or sulfacetamide, those agents are bacteriostatic. They're not bactericidal. So they won't kill the organism, they're just going to knock it down a little bit. You want to put some antibiotic drops in the eye just to soothe it, fine. Sulamid is fine, it's not going to be a problem. If you want to kill something, that's not the right agent. Okay, iritis, same thing as uveitis. Inflammation of the anterior portions of the eye, behind the cornea, all kinds of causes. There can be connective tissue disease causes, but you can also have traumatic causes. We're going to treat them the same initially. And steroids are usually indicated if it's a medical cause, but I would have the ophthalmologist make that decision. And so for the physician assistants and the nurse practitioners, I'd make sure that either you call the ophthalmologist or you get the doc who's working with you involved and they call the ophthalmologist. People are going to have pain, they're going to be photosensitive, and they're going to have a constricted pupil. Any other ocular problem that you have will try and improve vision by dilating the eye to a certain degree and let more light in. Not so with iritis. You will get constriction of the pupil. And so if you have a constricted pupil and a red eye, it's going to be iritis. Other causes of the red eye, think about corneal problems like UV burns. It could be from the sun, reflected on water, reflected on snow or ice, but the most common is going to be from welder's flash. And just remember, there's about an 8-hour delay from exposure to the time of symptoms. So people will have a UV keratitis, and it will give you a punctate uptake of fluorescein. And they will have an intense iritis. I wouldn't patch them, we used to, but I would make sure they wear sunglasses so when you dilate them, less light comes in. Dilating them is stopping the spasm of the pupil from the iritis. Okay? Allergic conjunctivitis can cause a red eye also, and this is really helpful. Cobblestoning, and it's usually under the upper lid. When you flip the lid up, when somebody has, you think it's conjunctivitis, is it chemical? Did they get exposed to something? Is it viral? Is it bacterial? Is it allergic? Well, are you sneezing? Are you having allergic or hay fever type of symptoms? And let me see your eye. If you see cobblestoning, it's allergic conjunctivitis. Nothing else does that. All right, styes and chalazions. The nice thing is, and the take-home message is, they're treated the same way. Warm compresses, pain medicines, maybe some topical antibiotics, and refer them. But they're very different. A stye is also called a hordeolome, and it is an abscess of the lid margin. It is red, it is warm, it is tender and painful. But that is not the case with a chalazion. A chalazion is a chronic, sterile, granulomatous reaction of the meibomian gland. And that's in the mid-lid. It's in the mid-lid, not at the lid margin, and usually isn't particularly tender or painful or red. It might be a little tender, but not so much, and not as much as a stye. And they both get referred. Pingueculums and pterygiums, those are just fun terms. This is what separates us from the rest of the population, right? We get these cool terms to deal with. So you have an inflammation of the conjunctiva that causes it to thicken for some reason. Those who have chronic dry eyes, Sika syndrome, or even they're just out in the outdoors a lot, this can happen. So if this really just gets to, stays on the conjunctiva and doesn't cross over onto the cornea, well, then it's a pingueculum. If it crosses over, it's a pterygium. And I know that there is really a tendency to say, this has got to be easy. It's just mucus. Or it's just loosely attached. Look, I bet I can just peel this off. And you want to grab it with a stat and just pluck it. Don't do it. Bad things will happen. Bleeding things will happen. People will scream. You just refer them. There's not a whole lot you're going to do with this. Recognize what it is and tell them there's a pretty cool term that you can use to describe it and refer them. Do not try and treat it in the ED. Okay, dacryocystitis and dacryoadenitis. Dacryocystitis is either an inflammation and or infection of the lacrimal sac. Adenitis is the same, but with the lacrimal gland. So cystitis, we talked about where the sac is. Inferior medial, right by the nose. Red swelling and tenderness. You don't want to think this is a facial abscess and start working into this thing with an 11 blade because you're going right into the sac, the lacrimal sac. Don't do it. And the lacrimal gland infection may be worse. It can be seen with Sjogren's, can be seen with sarcoid, some connective tissue disorders. And either one, if not treated, can make the other one get involved. And they need to have oral antibiotics and close follow-up pain medications. They might be expressing purulent tears. There may be obstruction. They may not get anything out from their tear ducts. Be aware of them. And with dacryoadenitis, the swelling is going to give you a mechanical ptosis. So it's going to be superior lateral swelling. Just a good sense of where the structures are. And orbital and periorbital cellulitis, just a couple comments here. Periorbital cellulitis is an outpatient disease unless you have comorbidity. Okay? It's around the orbit, it's not in the orbit. It can be from local disruption, it can be from local infection. If it's bacterially seeded from another infection, well, of course, you might want to admit that type of person. But here's the difference. When you have orbital cellulitis, it's within the orbital septum. If you have inflammation, fluid, pus, anything building up in the orbital septum, it's a closed space. You can cause retinal ischemia. They can lose their eye. They could have proptosis, pushing the eye forward. And this is something that's very important. They'll look sicker. They'll have violaceous red lids. And when you ask them to move their eye, they're going to say it hurts. With periorbital cellulitis, extraocular muscle function does not hurt them. But with orbital cellulitis, it absolutely does. The #1 complication of orbital cellulitis, a lot of people don't know this, is actually meningitis. So if they don't look right, you may want to consider an LP. Another not too uncommon complication is cavernous sinus thrombosis, and the most common physical finding that you will see with that is a cranial nerve 6 deficit, the abducens nerve, that moves the eye outward, so they won't be able to do that. So if it's on this side, you ask them to look out this direction. This eye will move this way, this one will not. It gives you a sense that it could be a cavernous sinus thrombosis in the context of orbital cellulitis. Orbital cellulitis gets admitted. All right, subconjunctival hemorrhage. Usually it's not a big deal. It's idiopathic, but if they are on anticoagulants, you may need to check an INR if they're on Coumadin, whatever it is you need to do, make sure that if there's a correctable cause, that you correct it. But the traumatic version is more concerning. And if you have a conjunctival hemorrhage, subconjunctival hemorrhage that's huge, matter of fact, it's covering the whole sclera and conjunctiva, that's actually a bloody chemosis. That is one of the more common findings in a globe rupture. Now, in a globe rupture, if you're lucky to see it, you'll get a pinpoint pupil, and the point of that pupil will be pointing at the area of the perforation. But just because you don't see it doesn't mean it doesn't exist. Anytime there's a bloody chemosis and the whole eye is involved, think about perforation. Very important. Acute glaucoma, we're nearing the end here. This is a true ocular emergency, very time sensitive. And what happens? We talked about this. In the back of the eye, we have the vitreous humor, and aqueous humor is in the front of the eye. It's produced by the ciliary body, and it kind of floats in between the iris and the lens and goes into the anterior chamber and flows back out through the canal of Schlemm and is reabsorbed by the trabecular meshwork. And this continues to go on over and over again. Unless you have ciliary body hypertrophy, iris hypertrophy, and then when your eye dilates, it folds up like an accordion, obstructing the canal of Schlemm. And now you can't get that fluid out, but nobody told the ciliary body to stop making it. So it continues to create it, it cannot release it, and now you have acute angle closure glaucoma. Anything above a 20 is a concern. Usually these people, when they present with their steamy, hazy cornea, headache, red, painful eye, their numbers are 40 to 70. They're pretty high. They will present oftentimes with a mid-sized, non-reactive pupil. And again, headache and nausea will oftentimes be present. They'll give you a history frequently of being in a dim area, dimly lit area, like a movie theater. So the eye dilates, and then they have the onset of eye pain. Needs emergent intervention, such as things to decrease aqueous humor production. Acetazolamide will do it. Topical beta blockers are easy, so go ahead and do that. You can put some steroids in there, probably not the first-line agent. And pilocarpine is very, very important. It is a parasympathomimetic agent, which will help constrict the pupil, and if it constricts the pupil, it facilitates drainage of that aqueous humor. The problem is, early in this disease process, there is a pressure-induced ischemic paralysis of the iris. So if you give pilocarpine first, before you reduce the pressure a bit by stopping production of aqueous humor, pilocarpine isn't going to do anything. You've got to do the other things first, then pilocarpine. All right, the red eye algorithm, I'll let you review this at your leisure. Just gives you a sense of what things to look for in the painful red eye, what symptoms you may have, and what diagnostic entities you need to consider. We've discussed almost all of them. So eye problems to consider referring. I love the first one. So all patients who have only one functional eye. If anybody lives by the coast, any pirates running around, they get referred, okay? All patients presenting with lacerations, lid margins, we talked about those. All patients with a new onset of visual disturbance. You have diplopia, you have a significant reduction in visual acuity, particularly without a good reason for it. You don't have iritis, or you don't have a significant corneal abrasion over the visual axis. You've got a corneal abrasion, but it's not that big, and you've got visual acuity that was previously normal, now it's 2200. There is a problem. They need close outpatient follow-up and referral. Thanks, everybody. I hope you'll stay for the Q&A.